Good to see you.
Okay, can we make a start, please? She's going to walk around so she can't. Sorry. Somebody lost the mobile mic. So, yeah, I presented one to the extra obviously. Can you share these around? Can you share these around? Okay, good morning everybody. Welcome. Hey, get off the stage.
I'm proof that the heart works.
Okay, yes. Despite adverse circumstances. So, welcome everybody to there's plenty out there. So, welcome. Thank you for giving up your Sunday morning to come here. I hope you'll all think it's worth it. Before I hand over to Francis, who's our star turn today, just a couple of words. Why are we here? The answer is because over the last 18 months, 2 years, people I know who are really healthy, who look after themselves, who fall off the bottom of the scale of risk factors for any form of cardiac event, have started having very unexpected things happen to them. Some of them, sadly, aren't here to be able to talk about it. Some of them are. Ian, I think you said you didn't mind being identified as a poster boy. So Ian is one such person, healthy, fit, great cyclist, and suddenly, almost out of the blue, a near fatal heart attack. And being a lawyer, my antennae started twitching a bit. How can this be? How can people be paying large sums of money to get health checkups every year, and yet it's not, their potential is not being spotted? Something is not right. So Francis very kindly gave me a kind of tutorial about these things, and we discovered that many of the screening methods that are used in the routine health checks may not spot a potentially fatal condition. So Francis kindly agreed to give us all a mini tutorial about heart health. She's even given you, being keen students, a couple of pictures there, so that as she talks you through it, you can see what's going on. A big thanks to Peter Grieber for lending his printer to print these out, since I gave mine away. And thank you, as always, to the legend for laying on the event and making life very easy for us. We will, I'm recording this, by the way. Hopefully, if the recording works, I'll put it up so you can click on a link, and if you have any friends who would have come but couldn't, then they can have a look at it. And at the end, Francis and I will send out a note with a summary of what we've talked about. We didn't do it beforehand because there may be some things that come up that we can include that we couldn't have given you if we'd given you it before. So before I hand over to Francis, does anybody have any questions? Okay, good. So Francis, as you would have seen in the meeting note, those of you who saw it, is a retired nurse with a master's in cardiac.
Well, just a master's in nursing, but it's specialty in pulmonary.
Okay, yeah, so she knows whereof she speaks. And in addition to her working career in the US, she has very kindly given her time to help some of the people in our community who've had cardiac issues, and so is really the best person to talk about this. So, Francis, over to you.
Well, thank you. I mean, there's a lot of people here today, so I appreciate you all coming. So let me just ask the leading question. How many of you in this room have either had somebody you know or yourself had some kind of cardiac event? Okay, are there just a few that haven't? I should ask the reverse question. Okay, all right. And at our age, most of us in here, we need to realize that we are at higher risk, even if we've done all the right things, okay? And so as Paul has said, this is probably a good time to do this, and please, it's not a very complicated talk, so I'd like you to ask questions as we go along. If we get too many questions and I can't complete the whole process, then I'll stop you. But other than that, I prefer the dialogue, okay? And I like walking around, I can't stay still. So can everybody hear me?
Yes.
Okay, good. Then I don't have to use a microphone. All right. Okay, let's start with what we said in the original newsletter, what was going to be our objectives, all right? So obviously we want to talk about the main aspects of coronary artery disease. Keep in mind, we're only talking coronary artery. I'm not talking about arrhythmias. I'm not going to talk about heart valves and that kind of stuff, all right? And how you can be at risk even if you've had a healthy lifestyle. As Paul mentioned, we have many of our comrades here who very healthy, very fit, and have had some major complications from coronary artery disease. Okay, what kind of screening we can do to keep ourselves as healthy and as knowledgeable as we can about what's happening with our heart. What you can expect with the actually cardiac screening, and then what I can share with you about what I know about the hospitals in terms of what they offer. Now, some of you may know more than me on that part when we get to that. But pretty much all the hospitals have some form of cardiac care. Now, some are better than others, or maybe not so good at all. But we'll talk about that a little bit more. So, let's start with, you got your pictures there, and I'll have them up here. Just a little quick review of how the heart works. Because without the coronary arteries working, the heart doesn't work, right? So, yes?
I already have a question on this. This obviously should be like this, right?
Yes.
Yeah.
Yes.
But I thought the aorta runs down.
Well, it goes both ways. We'll show you. I'll show you. I don't have a pointer, so I'll have to get up there with my fingers, all right?
It's a digital presentation.
Yeah, okay. All right, so let's just do this. You got that, this is the one in color, all right? So this is the basic anatomy of the heart, and you need to know this because all the pieces have to go together for it to work properly. So the blood comes in from the superior vena cava. That's all what we call blue blood, meaning it's not oxygenated, right? So it comes in through here, as you can see from the arrow, goes into the right atrium, then it flows into a valve into the right ventricle, okay? That's all unoxygenated blood. Then it goes out to the pulmonary artery, and that's where it goes into the lungs and gets the oxygen, okay? Then it comes back, and it comes back into the left side of the heart, left atrium, through another valve to the left ventricle, and then pumped out. So your question is, it pumps. See, it goes different ways. Some go to the brain, the first place it goes is the coronary arteries, and then it goes down. So you've got several branches of the aorta that feed the whole body. And it's that portion, that blood that's pumped out of the aorta, is the one that provides all of the blood to the rest of your body in addition to the heart. Okay? I'm going to talk about this a little bit. This right here is called a septum. It basically separates the right side from the left side, and it's a muscle, and it has some importance, and we'll talk about that next. Sorry I have to do this. Oops, keep going wrong way. Okay, so a little bit on the anatomy of the coronary arteries, because that's what we're talking about. That picture, I think that probably shows up much better on the diagram. But the importance of the coronary arteries is that it is the blood supply to the heart, okay? We talked about the blood that goes out to the kidneys and it goes out to the brain, but it also supplies the blood supply to the heart. And if you'll see, this is the aorta. It gets first choice of the blood. When it's getting pumped out, that is what goes first. That's what we need, because if we don't have any blood flow to the heart, we don't have any action. Okay, so this is a simplified version because these all branch off into, excuse me, very small portions. So there's two main coronary arteries. One is on the right here. the right coronary artery, and that feeds the whole right side of the heart that you saw in the diagram, the right atrium and the right ventricle, and it feeds 1/3 of that septum, the one that was in the middle. Okay, and you say, well, why is that important? Because the septum has in it the nodes, the electrical nodes that make the heart fire. So, let's go back a little bit. You need 3 things for the heart to work. You have to have a pump, that's what the muscle of the heart is. You have to have blood flow, and you have to have electrical impulse, okay? So you gotta have all 3 of those things working for your heart to beat, okay? So those nodes I was telling you about that are electrical nodes in the septum, that is supplied by the right coronary artery. So people who have right coronary artery problems may manifest as an arrhythmia, not necessarily changes in your EKG, and that's in the normal sense, but you have arrhythmias because those nodes that fire are not getting the right impulse because they don't have blood flow, okay? So people who have right coronary artery disease, severe enough, they will most likely have arrhythmias as part of their problem, and that will show up on an X-ray. I mean, excuse me, an EKG. Yes?
Can you say that last bit again? People who have,
The right coronary artery problems, they will most likely have abnormalities in their electrical system.
in the electrical system, okay,
Yeah.
thank you.
So the nodes that fire and make the heart beat, that's not getting not necessarily good blood supply if you have disease there. So then, therefore, not good blood supply to those nodes means you don't get good firing. And so you don't have a regular heart rate and a regular rhythm. It gets irregular. You have fast heart rate, or you have, can have some very serious arrhythmias. Yes?
So, if I understand what you're saying, that's the rationale for using an EKG to check for potential heart disease.
Right.
Because if there's misfiring, then it could indicate.
Right.
But I think what you're going on to say is that you can have heart disease, potential heart disease, and a perfectly normal EKG reading.
Yes,
Yeah.
you can.
Okay, thank
You
you.
can. But if you have arrhythmias already, that may show up more sooner than if you had left heart disease.
Okay.
Okay. Okay, so going back, we have the right side, which is mainly the right coronary artery, and then the other left side has 3 branches. The first one right there, you see the left coronary artery, they call it the main coronary artery. It is the big guy, okay? Problems here are really bad news, okay? Because that is the first place where the blood goes. And you have the whole ventricle, which is the most important part of the heart when it pumps. It works 60% of the heart on the left side, 40% is on the right side. So it's very important that the left side get good blood supply. And then it branches off to the circumflex, and then it branches off to what they call LAD, which means left anterior descending. Left side, anterior being front, descending down. That is the place where most of the clots, coronary artery disease and clots occur. And mostly there, okay? Okay, questions on it? Yes, Lois?
Which one is known as the widowmaker?
This
That's
one.
the left anterior descending.
Yeah.
Yeah.
She refers to widowmaker, because it's kind of like, what's happening to some of our friends here is that you have no symptoms, and then all of a sudden, you're like this, okay? And that's what can have an acute blockage there and do that.
Can I feel an arrhythmia?
You should, not all the time, it depends on what it is. Arrhythmias are,
So it could be silent that you're having these things, but
a
you
lot of
can't
people
tell.
who have atrial fibrillation, which is a little bit of quiver, sometimes don't feel anything. It shows up on the EKG, but not necessarily. But if you have a PVC where you have a big contraction that's abnormal, you'll probably feel a little palpitation. And that's actually quite normal, as long as you're not having them beat after beat after beat, okay? Yeah. Yes?
Can you say 2 words to the heart size and the size to the aorta? Because the diameter is quite high and a lot of people probably don't know that.
I'm not understanding, I'm sorry. Say that again.
Okay. Can you say a few words to the heart size and the size of the aorta?
The heart
Because
size is
the-
about this size.
And the aorta is quite big, and a lot of people don't realize that.
Mm-hmm.
30 millimeters up.
I
It
don't know.
depends.
I really don't. I just
No,
know.
no, I know. So
Yeah.
it's 30 millimeters. It depends on the body size.
Yeah. Mm-hmm.
And it can, so 30 millimeters, it's quite
Yeah.
a big diameter, and a lot of people don't realize that.
But
So
that's- you're
and this
talking-
one goes,
Yeah, you're talking about the aorta.
yes,
Yeah,
yes.
okay. The coronary arteries, if you were to look at the right and left, they're about the size of a straw in terms of their opening, okay? So that can give you an idea of, I mean, it's pretty good flow, but you can imagine if it starts to clot up. Okay, let's see, I'm gonna do that next. Okay, so what is coronary artery disease? Anybody want to take a guess? Basic, anything?
And a little blocked blood flow.
That's right. It's basically what we call atherosclerosis, means that we have blockage or plaque buildup in the coronary arteries. It's really simple if you think about that. But that's all that is. Yes.
But the arteries, they have high pressure, right? They're under a lot of pressure.
Yes.
And blood goes through them pretty
Right.
fast, a lot faster than
Yes.
through a vein.
Right.
So the chance of plaque or anything is less than in the vein, you would say, because the blood goes so much faster, there's no room to
Well,
chill out and do some plaque.
Well,
Or whatever.
yeah, I was gonna say, it doesn't quite work like that. It's just well known that the arteries, because you're right, they take the brunt of the pressure, okay? So things are pushing through there all the time. So there's a more propensity for you to build up your plaque in that area. And plaque is made up of several things. It's made up of cholesterol. We all know about cholesterol because everybody says control your cholesterol. Well, it's also made up of some fibrin, a little bit of waste product, and a little bit of calcium. All of those things, when they start, they clog up that vessel, then it just keeps getting worse and worse and worse if you're not doing anything about it. Yes?
Can you reverse that? Or does it only build up?
Well, if you were 20 years old, I would say,
I was,
yeah, right, that you could probably do something with that, yes. But it's usually, you can control it to a certain degree. You may be able to stop it, but it may not, it's not gonna make it go away if you all of a sudden start exercising and start doing all the right things. Because some of the buildup's there from over a long period of time. And that's the thing about coronary artery disease, it's kind of silent like the widowmaker. This is happening and you don't know it, and you don't have any symptoms. It's very common. Yeah. Just like you can build up anywhere, but the heart is more important. Yes, Paul?
The question about can you diminish it after it's been identified? Klaus, who isn't here today, who was another victim who fell off his bicycle and was just rescued, found a book written by a fairly eminent American cardiologist, and I'll try and remember to send it
Oh,
out to
can you stand up, please?
Yeah, sorry. He found a book written by an eminent American cardiologist who has recommended to his patients a completely vegetarian diet, in other words, a non-Western diet. And some of his patients have experienced a demonstrable widening of their arteries. He's got pictures that look rather like the ones we're going to see later on, but the other way around. So they're blocked and then they become unblocked. But this requires you to give up all animal fats. I mean, a complete vegetarian diet with no, I think even not vegetable oils. You can read all about it in the book. So it is possible to do it, but at the cost of an extreme lifestyle change that, looking around this room, I don't see many people willing to do.
Well, and that's the thing is that if we were all doing this every day religiously since we were 20, it'd be different. But you know, it's very hard. Like we talk about the mass fatigue. You can't keep that up all the time. So you're going to splurge here, and sometimes you might get a little overweight. You lose your weight. Your blood pressure goes up, then it goes down. Those are things that take time over time, and as you age, that's going to happen. To the degree of the blockage will depend on your individual situation.
So it's a natural way of life that older people have more problems than young people. because of all these factors.
Well, that's part of it, yes. But there's some things we can do, and I don't wanna say that there's no way you can prevent that, okay? But you can, and those are the things that we've talked about, okay? Let's make sure we exercise more, okay? Let's make sure we eat right, not much fat. Keep your blood pressure under control. And that's one of my pet peeves, is a lot of people say, oh, my blood pressure's 140/90, it's not that bad, I don't need to worry about it. Well, you do, because the new regulations that came out, probably 5-10 years ago says heart rate needs to be the blood pressure 120/80. Well, that's kind of the magic number, but it's hard to get there. So a lot of us who are older, who have possibly coronary artery disease or other disease in the vessels, if your blood pressure is going up, it means you are pumping harder against anything. So as you have to pump harder, you put pressure on all the vessels, not just the vessels of your leg and your kidneys, but also on your heart. So blood pressure control is really, really important. And a lot of people say, I don't want to take medicine for my blood pressure. Well, if you can't control your blood pressure through your diet and your exercise, then you really need to consider that. You really do. And the medications now have almost very little side effects compared, and there's so many choices. So if this one doesn't work for you, another one will. So that's kind of my Francis pet peeve, is that I think it's really important.
I just mentioned in passing now, but people could ask me later, there are 2 or 3 great natural supplements that very much control your blood pressure.
Yeah, there are. Some people have done very well with that, and some people have also some side effects from that. So it's your choice. But whatever you choose to do, whether you do that from that way or through the other pharmaceutical, get your blood pressure down. Oh, that's key. And you have to do that. To do that, you need to monitor your blood pressure. So, I would say for me, because I have that problem, you see how hyper I am. I have blood pressure problems. But I control that with my medication. So I measure my blood pressure every day. Now, some people, who have, pretty comfortable with their normal level, maybe once a week, once a month. But that's something that you should monitor, and it's pretty easy to do. And if you all of a sudden get one bad reading, well, you need to take it more, because you may have just done something to make the heart rate go up normally, okay?
Can I stress that you need to be taking your blood pressure check when you're relaxed and at home?
True.
You've got to be chilled out when you take it. You need true reading. Because as soon as you go to the hospital, I love it, you go to a hospital. I was going the other day to have a tooth repaired. She said, do your blood pressure. I said, why? You're going to stick a drill in my mouth.
Yeah, right.
I knew it would be like 145/90 because I don't like dentists.
Yeah, but that's not entirely benign. Think how
No, it's
many,
not benign. But
right, think how many times a day that we're stressed. So
Yeah.
this is
yeah,
our body
stress is a
response.
normal part.
Right.
It's meant to do this. But the actual reading you're controlling when you do I need to take more pills is when you're relaxed.
Okay.
Because when I'm sitting at home, mine is like 115 or 120. It's not a problem. But give me a dentist.
And if you exercise, your heart rate's going to go up, and your blood pressure's going to go up. That's part of what you do. Yes.
Can you use medicines and natural supplements together?
Yeah, I don't see why not. It's just a matter of, does it control it? You don't want to bottom out. That's worse too. So it's just a balance. I don't see that it's contraindicated.
You do need to check the drug interactions because so-called natural have got very strong chemicals in them.
And they can affect not necessarily heart medicines, maybe affect another medicine that you're taking. So yeah, but that's really between you and your physician to talk about those kinds of things. And be upfront. If you are taking a natural substance, be sure to tell your physician that, because then they can take that into consideration. Now, they may not understand it all, but you need to talk about that.
Can you put those natural medicines in your note when you send it out?
I can, thank you, yeah.
At what level do you believe that you need to take medication? Is that over 140 or over 120?
Yes, if you are, now they're saying if you are over 120 on some consistent basis, you may want to consider a low dose medicine for your blood pressure.
If you're over 120,
Yes, 120 over 80.
Oh my goodness.
Seriously, I mean, everybody used to be 140 over 90, and that's been changed
Yes.
because it's 120 over 80.
There are issues with that. If you've been running at 140 and you get to the age of 75 and you try to go at 120, you'll find yourself in hospital with a head injury.
Well, you could, that's true.
Yeah.
That's the benefit of any medication you take. It doesn't start right away. I mean, it does take 2 weeks before anything's going to take effect. So you should be able to monitor that. If it drops too much, then you need to be concerned about that. And that can happen. I find it's more that people need to up their medicines than they need to lower them, is what I see in my experience. Just to comment on the coronary artery disease, it is the leading cause of death worldwide, not just in our Western world, worldwide. Okay? And the biggest complication of coronary artery disease is a heart attack. No blood flow, heart doesn't work. Okay? Yes?
What exactly did you say is the leading cause of death?
Coronary artery disease,
Coronary artery.
which is what we're talking about. Diseases of any of these arteries. Okay?
But that could be a conglomeration of different things, coronary artery disease.
Well, that's what we're trying to define coronary artery disease as that disease that affects these blood vessels that supply blood to the heart.
Oh, okay.
Okay?
So what about high cholesterol and low blood pressure?
No problem.
Well, can I come back on the cholesterol?
Absolutely.
Okay, yeah, okay. Anyway, I didn't mean to sidetrack on my pet peeve, but I'm just verbally on that. Okay, we talked about prevention, exercise, diet, blood pressure, those good things. Okay, so what I'd like to do now really is kind of put some of this a little bit more in perspective from the case studies. And we have one case here. I've got 4 case studies. I just want to tell you the scenario. I will get into more detail about the diagnostic part and the treatment part later, but I just want to put it kind of more personal and more at home. Okay, we got case number 1, and I guess it's okay to say his name now?
I guess it is.
Okay. Klaus, y'all know Klaus, about 1.5 years ago, 2 years ago. He was on a big time bike ride up one of our big hills, Doi Tong, I believe, on a sanctioned bike ride. Very heavy duty biker, as you know, many kilometers, strong, fit, had a heart attack on the hill. Klaus. Had to be resuscitated, had to be brought to the hospital, and then had to be transferred to the main regional hospital where he had some procedures done to take the blockage out. So you would think, when you look at Klaus, really, does that look like a guy who's ready to have a heart attack?
Never smoke, never drink alcohol.
Doesn't drink, no, he's, I mean, I don't know if he doesn't have alcohol, but I mean, he's not a smoker, he's fit. You just think, well, that shouldn't happen to him, but it did, okay? And he was pushing himself, and that's the point, is you're pushing yourself, and if you have some problems there, sometimes the heart can't compensate for that when you're going. Okay? Now, I don't know I don't know the details of what particular artery or arteries were affected. I do know, though, that he had a workup at Mayfall Along, just a regular general history and physical that included a resting EKG that, on retrospect, if you looked at the EKG, after we already know what happened to him, there were some changes on the EKG that could have warranted possibly another step, maybe a stress test. But hindsight, the physician looks at the report and he says, well, that's kind of within the range. So, and plus with his look and his nothing going on, they didn't push it anymore. Okay, so that kind of goes to the point that we have these silent things happening, that there were maybe some subtle changes that could have been evaluated more, but it's very difficult. Okay. Yes.
When you say change, do you mean looking at 1 year versus another year, or actually looking at the static report that they have for that particular test?
Well, they're going to look at that test. Okay, so if that test has some abnormalities in it, then it should warrant further testing. But you also want to compare to your baseline. So if your baseline, like my baseline, if you looked at my heart, my baseline heart rate looks like I had a heart attack 50 years ago, okay? And it corrects itself when I exercise. So you have to compare, you do, Marty, the point is, you do have to compare against your baseline, but you have to look at it at that time too.
Yeah, I'm just questioning if the doctors here actually do that compared to previous studies.
Well, that's a very good point. If you see the same physician and you have a medical record there, then they will see that, okay? If you move around, then I would recommend you carry your baseline EKG with you if you're going to go for a workup. I do when I see a new doctor, because I know what they're gonna say. Oh my God, you know? So, yeah.
Francis?
Yes.
Just to say, I used to have my medical checkups at Bangkok Hospital in Chiang Mai, but I guess it's the same as the one here. And I was incredibly impressed when I went along for the second one. They actually had my earlier one there, and they were comparing like with like, which is exactly what they should do. But as Francis says, even if you go to the same hospital repeatedly, that's not guaranteed. And if you go to different hospitals, then unless you carry around a fistful of results, then you're not going to get that comparison.
Francis?
Yes.
When you say within the range, in engineering it's 10 or minus 10%. In medical terms, when you say you're within the range, what is it? Are you on the safe side of things or on the dangerous side of things?
You're measuring milliliters on the trace.
Yeah.
Literally.
Jacques, I'm not sure I can really answer that question.
It's impossible.
When you look at an EKG, for say, you can say, okay, well, this little part here is a little bit more than it should be.
I mean, like blood pressure and other tests.
Oh, okay.
Where you say this is the average, and if you're there, that you're within the range. But what is that? You know, how big is that range?
Well, it really needs, like I said, on the blood pressure, the 120, over 80. But that's going to go up and down depending on what you're doing. But the range should be probably no more than, 130-ish, okay? If you start pushing up to 140 with the new guidelines that have come out in the studies, that you're pushing the envelope, that's going to be your consistent blood pressure, okay? And we didn't spend too much time on cholesterol, but I want to maybe help answer that question related to the statins. When we talk about prevention, one of the things you can do is to control your cholesterol level. And that's something you would do on either maybe annual basis, maybe every 6 months, depending on what your numbers are. But the trick is for your cholesterol, you basically want it under the whole total cholesterol under 200, okay? And then you have two parts to that. You have a HDL, high cholesterol number, and a low cholesterol number. HDL is called good cholesterol. The more of that you got, the better. So if you're in the 60s, 70s, good. Low cholesterol levels should be under 100, okay, because that's the bad cholesterol. So that's kind of the normal baseline, but you need to know what your baseline is. Mine's borderline, but I have a very high HDL, so I'm not taking a statin because of that. If I had a very high LDL, I might be, okay? So your question, sir, was about taking a statin along with having a normal blood pressure?
No, my question was, if you have normal or lower than normal blood pressure and slightly elevated cholesterol, what then?
If your cholesterol level, and again, if you have a good HDL, maybe not. If you have not a very good HDL and you have a very high LDL, bad cholesterol, then maybe you would.
I have issues with cholesterol, as a physician. When WHO first started bringing out all these guidelines, I was a young GP, and WHO came along and said that as 80% of British Caucasian Northern Hemisphere males had high cholesterol, the whole of the UK population should be on a statin. And so we just pointed out to them, if 80% of us have high cholesterol, it means it's normal. Cholesterol is a risk factor on its own, it's not a risk factor. Okay, my cholesterol's been 220 to 221 ever since I was the age of 21. Okay, so then treatments. If you just reduce cholesterol using a drug that's not a statin, you do not alter mortality or morbidity. If you use the statin, you do reduce mortality and morbidity because the statin protects the endothelium, the lining, and stops inflammatory processes which minimises plaque production and so on. So cholesterol lowering is not the key. It's actually the health of the lining of the artery, and that's how statins work. They produce their effect not by reducing cholesterol, but by reducing inflammation. So your cholesterol, forget it. Now, if you are overweight and type 2 diabetic and you smoke and you drink a bottle of whiskey a day, then your cholesterol definitely has an issue because you're just asking it to clog up.
So are you taking statins?
I do, for my endothelium. I don't care about my cholesterol. I can measure it every week if they
And how
want.
can
It's
you
always
measure
been
the health?
220, and it's
And he's saying that too. Think about what he's saying. He said he had that when he was 20. Okay? Usually most of us, if we get any problems, they're slowly building up. So that's his norm.
It's
Okay?
normal for me.
Yeah.
But I take a statin because I know that will minimize my risks.
And how do you establish the health of your endothelium?
You
Well,
can do a stress test.
Yeah, that's what we're going to get into
And
now.
you'll get into that.
Yeah,
And
we're going
again,
to talk
we'll
about that. Yeah.
because
And I
I'm
don't
not-
really
I'm not
want to
happy
get
about
into.
doing stress tests at my age.
Please,
I think
Lenny,
I'm more like to killing myself doing a stress test.
Well, okay, well, we won't have you be our demonstrator for that. But I don't really want to get into the statins stuff. There's ways to reduce, the point is, you need to monitor your cholesterol level. Whether you say that's high or low, your baseline, you look for the changes, okay? And then other factors go into that in terms of, like I said, you have HDL, LDL. And then there's a whole controversy about statins. People say, oh, you know, they're not good, or, you know, I really don't want to talk about that right now. If we could just continue on, and then, because there's a lot of reading to do about that, and a lot of pluses and minuses, and it's all individual. Some people have great responses with it, some not so good. All right, second case study is Ian, who, as I know, is a biker. Does he not look pretty fit to you? All right. Was biking, I understand, and
Yeah.
fell, heart attack.
Yep.
Okay, so
Yeah, if it's my,
want to just maybe, if you don't mind sharing just a little bit
Yeah,
how
sure.
that all happened?
Yeah. Some of you know me, some don't. Ian Davis. I have a very good friend in Chiang Rai, Adam Karab. Some of you may know him. He's a very, very good biker. He has ridden from the south of Thailand to Chiang Rai on his bicycle. Adam and I were going to repeat that ride about 2 years ago, just before COVID. We were training hard for that. COVID obviously stopped us travelling, so it didn't happen. We decided we were going to do that ride again now, right now. So I was in training for that ride, and I was doing many rides solo, up to 100 k's a day, regularly. I was out riding, absolutely fine, by myself, coming up the highway just south of the White Temple, and bang. I remained conscious, and I was able to telephone Adam. My wife was at home, but she was still in bed, and she turns her phone off when she goes to bed, so I knew not to ring her. Luckily, there's a hospital just across the highway from where I was. Had an ambulance on standby there, which came round and picked me up and took me into town, and asked them to take me to Subarin Hospital, still early in the morning. They took me there, and the cardiologist had just arrived at the hospital when they brought me in. He took one look at me and knew what the problem was, and straight into theatre. My problem was a STEMI, which is the widowmaker, total blockage of the artery, left coronal, total blockage, no heart flowing, no blood flowing at all. I was conscious through all this, and luckily survived. But this heart attack came on with absolutely no warning at all. I was fit, healthy, my cholesterol was bordering on high, but it always has, so it was normal for me. No reason at all for me to have a heart attack. I don't drink any alcohol at all. I've never smoked. I eat healthy foods. I don't eat very much meat. And even when I do eat meat, don't eat any red meat. So it's white meats I eat, and very little of it. There's nothing I could do to improve my diet to make me any healthier that I could see without some luxuries in life, of course, and for no reason at all. Bang. So lucky to be here. Yes, sir.
Yes, question. Family history of heart problems.
None at all. Absolutely none. Both my parents lived into their 90s.
Okay.
I have 2 brothers, 2 sisters. Well, fine. No one has any heart problems in my family.
Did you have a medical at any time just before the incident?
I was due for one. It's been over a year since I've been for one, but I have regular checkups. Yep.
And in the one you had a year before, what did they test and did they find anything?
Just a general test. Didn't do a stress test, but did an ECG, echocardiogram, but not an echocardiograph.
Okay.
Nothing. Fine. Didn't expect them to find anything, and they didn't.
But did you ever do a stress test?
Yes, I've done, because of the nature of the work I was in when I was in Australia, I was running some big construction jobs in remote areas. So they wanted people who were fit and healthy in these remote places.
And how long before your incident was the last stress
Last
test?
one, probably 4 or 5 years. They're going, never any problems.
So you're saying, I'm not quite understanding, you're saying everything seemed to be fine. What created your situation?
It was a blood clot.
A blood clot?
Yes, a clot.
What will probably happen if you have a stable plaque inside the artery, and for some reason it starts to lift up, it snaps off. So now you get turbulence, now you start getting blood clot formation, bang. But what triggers that plaque to start becoming unstable is another story. We don't know.
Okay, so we don't know. So
You don't, and you never know what's going to happen.
So I'm just saying, everything seems fine, truly, and then he has an attack. And you're saying that's loose plaque?
Probably the plaque started to get loose, you start to get turbulent blood flow.
Created some turbulence.
And then blah, blah, blah. It's very simple, and you can have every test in the book. And
So in other words, hard to feel confident that there won't be any problems over here. Is that right?
We're going to talk about some of the things that we can do to at least better understand where we stand with our heart health, and particularly the coronary arteries. So Ian, thank you so much. Appreciate it. Okay, now the third case is also another expat, somebody who, again, pretty healthy, religiously monitored blood pressure, cholesterol, calcium score, did all the right things, ate, changed diet, did all those things. He went to see this physician just to get a refill on his statin medication and his blood pressure medication before he was going to travel to the States. Well, he gets there and his blood pressure it was like 170 plus. You know, he thought, oh, it's white coat syndrome, you know, for example. But it just never went down after he was there for quite a while. So the doctor said, oh, no, not good, thank God. And said, we want to do a stress test. So they did a stress test on him, and for lack of a better term, he failed the stress test. He went all the way up pretty much to maximum. We're going to talk about that a little bit later too. Maximum plus a little bit more the physician pushed him. But he had severe arrhythmias. He had ventricular arrhythmias. Pretty severe and a lot, not just onesies. So stopped the test and then went for angiogram, which is where they put the dye in and take a look, and found that he has 3 blockages. He had the right coronary artery, 95% plus, okay? The left circumflex and the LAD, both of those are out 90%. So he had basically 3 blockages that they found when they did the angiogram. But he had to be pushed on his stress test. And the reason he didn't have other symptoms, because he just didn't. His problem was the right side, 95%. And what did I say about the nodes there? They are supplied by that side, okay? So he was not getting good as he was working out, not getting good blood supply, affecting the nodes, which was causing the change in rhythm. Okay? That was his symptomology. He didn't have shortness of breath, none of that kind of stuff. But the EKG changes were important because of the arrhythmia. So he went and had stents put in. He had 3 blockages, 6 stents. You can have more than one. You can have more than one stent to fix it. Okay. So he had 3 stents put into the right coronary artery, and he had 2 in the left, and I think 1 in the circumflex. Okay. So a total of 6. And he did those, and did the major one first, the life-threatening one, right away, and then he did the subsequent ones 2 weeks later. Survived, doing well. Okay.
In situations like that, is the stress test not like kind of dangerous because you're pushing it to the max?
It can be, but that's why usually the stress test is usually always supervised. They always have a physician there. They're looking at it, right? They're looking at your blood pressure changes. They're looking at your EKGs. At the time they're doing it. So they saw right away. They said, no, stop. So anyway, fine. 4th case is not quite such a good news, and I can share that. My friend Debbie, and you all know Debbie. Most of you do anyway. She is a victim. She did not survive. She had gone, she's pretty healthy, you saw. She's a pretty good exerciser and doing all the right things. And she'd gone back to the States to visit her family and came back and was starting her exercise regime, And she and I walked a couple times, a week, and she rode her bike and did other things, went to the gym and swam and did everything. But she came back and started her exercise, and then she started noticing chest tightness, not chest pain, some tightness when she exercised really strenuously. When she was riding her bike up the hill, when she was playing badminton, she was having some symptoms. So went to see the doctor, and unfortunately she just saw the GP and said, oh no, it's just muscle strain. So no. So we went for a walk, and I said, she got up from here to maybe that far and started having chest tightness. We're going to the hospital. Okay. So went to the hospital. She right away, we had the cardiac workup. She had the stress test. She lasted to 2 stages, maybe less than 5 minutes on that before she had EKG changes and chest tightness right away. So that was very quick. So she goes in for the angiogram, and this is what her problem is that she had 95+% blockage of the left main coronary artery. And that is really bad news, because if you have blockage here, what do you think happens down here? No flow. Okay. So that was where her big blockage was, and it was 95%++. She also had the circumflex with the clot and LAD, and a small portion of her right. Her right side wasn't as bad as the left. The left, she had 90% there. Okay?
Francis?
Yes.
Before I had my angiogram, they said to me they wanted me to agree that they said, while we're there, we might as well just do it.
Right.
So if you have over 70% blockage, we're going to
Put a
agree
stick.
now, rather than wait and come back.
Right.
We're just going to do it right then and there.
Right. Yeah.
And so why didn't they do that with her?
Well, let me first of all go back to the case study number 3. He had the option right then and there to do a stent. When they did the angiogram, he said, no, I want a second opinion. So he chose not to do that. Now, the problem with Debbie is that it's not very good to stent the left main coronary artery. That's 95%, that's the big artery. Plus, what good would that do if you didn't do the others? I mean, you've got to do the other 2 that are distant to that. So they said she's really not a candidate for stent. So even though they were ready to do it, she was not. So her particular situation, because of the severity of it and the location of that, was going to be a bypass surgery, and that's what she was going to have. And that was, bypass surgery is, we'll talk about that, a little bit more invasive, but it does the trick. Okay. So for her, she was not.
It's a big long block.
It's very hard.
You put stents.
And it was. I mean, almost the whole part of that. You looked at the angiogram. Was like, okay, that is definitely a heart attack waiting to happen, and that's what happened. Actually, she went home for her to get prepared. They had to order the blood and get ready for the surgery. But she went into the hospital the night before the surgery, and after dinner time, she had a heart attack and died. She didn't make it. 8 hours away from surgery.
Some 20 years ago, I was having pressure in the chest.
Mm-hmm.
Lasted a couple of days, so I called the doctor, and after they transferred me, he died, I think. He said, "You're having stress. It's not heart condition, it's stress." Now, when you say you have chest pains, are you talking here? Are you talking complete?
Well, everybody's a little different, but the chest pain usually is right here.
Center.
Yeah, usually. Uh-huh.
Okay.
Yeah.
And stress pains can be around.
Well, if you're stressed and you're really tight like that, you know, you could maybe have some tightness that would be viewed as chest pain. Yeah. But it's like anything else. If you have chest pain and it's lasting, the right thing to do is go get it checked out. Okay? Because you don't know what the story is. Anyway, so that goes to the next one, is that, so what are the signs and symptoms of a heart attack? You kind of need to know those. So what do you know as a chest pain? Everybody knows that one. What else? Anybody else know what other symptoms? Yes.
Sometimes jaw pain,
Yes.
sometimes pain down your left arm.
Yes, that's true. People don't realize neck, jaw, shoulder pain, referred pain can be a sign of a heart attack. Yeah, very good, very good. Sweating, yeah, perfect sweating.
What?
Cold sweat.
Cold sweat.
Yeah, yeah, pale, lightheaded, okay?
Don't you have something with stomach pains as well, for females?
Well, sometimes with the women, they don't typically have the crushing chest pain, but they can have like nausea. Yeah, sure, you can. That could be a sign.
Shortness of breath.
Yeah, shortness of breath. Sure, very classic.
Is sort of breathing for no reason.
Yeah, when you're exercising really fast, you're doing, that's different. So obviously, most of you do know the signs and symptoms of a heart attack. So if you do have any of those, please seek medical attention, okay? Because you really, if you can avoid getting a heart attack, that'd be better. Yes, Lois?
My mother had lack of hunger and a little indigestion the night, now probably 6 hours.
Really?
before her
Okay, the
heart
indigestion's the.
attack. Indigestion.
Fatigue also, extreme fatigue. Yeah.
She called me, she said, "I'm very tired and I'm not hungry." And for my mom not to be hungry,
Yeah.
I should have known, I won't forgive myself for that.
Oh, you can't go that way. I think about Debbie, what happened with her? You know, couldn't I have stopped that? No, I couldn't. You know. Okay, so now we're gonna get to the rest of the part. Yes, sir.
Well, I was just gonna say, you maybe know Tour Life, or New Tour Life. I was riding with him when he first had his first symptoms of blockage.
Who was that?
Tour Life Anderson.
Oh, okay, I don't know, okay.
Norwegian guy, Olympic bike rider. His symptom was heartburn.
That's kind of the indigestion, yeah. Because a lot of people will have severe heartburn, which can be viewed as chest pain. And it can hurt if you have really bad severe indigestion, but it can be. So again, check that out. Yes, so a lot of the symptoms are more subtle, and the women tend to have more subtle symptoms than the men. Yes, sir.
I had a friend who just really blew my mind when he told me he had a heart attack while he was sleeping and didn't even know he had it. Except one day he just said, "Boy, I'm feeling really crummy lately." Went to the doctor, and he already only had about 50% capacity in his heart, but didn't even know he had a heart attack.
Well, I'm sure that could happen. It happened to my mother, but she didn't make it either.
Okay.
Okay. All right, so what can you do to improve your odds of not having a scenario similar to the case studies we just talked about? Okay. One of the things that I recommend, and is in the literature, is that you should have a good cardiac workup, okay, or heart screen, however you want to say that. And there's certain things involved in that, all right? And some of that you may do because you have symptoms, or you may choose to do that because you want to know, like, where do I stand? Where do I stand? Okay. And depending on your situation, you may do this heart screen every year. You might do it every 3 years. You might do it every 5 years. Depends on how how your whole overall picture looks like, all right? So what's involved in a heart screen, and this is important, it's just not going for a checkup and getting a blood pressure check and an EKG, okay? It's a little bit more involved in that. So if you're gonna get a cardiac workup, you need to say, I want to the physician, we'll talk about that, I want a cardiac workup. I want to get all the way down to the exercise stress test. That's what I want to get to. So usually what will happen, when you get a heart screen, they're gonna check your lipids, okay? Even though you know your cholesterol, they're gonna see what your cholesterol level is. They're gonna take your blood pressure, and many times, if they do it right, they should take it lying, sitting, possibly standing, so you have some variation there. Sometimes, and take it with a real stethoscope, not the one they put in the hospital that's screened. You should have the physician do that. And if they don't, insist on it, because they all have spigs there, okay? They'll do an EKG at rest, so just rest, before you do anything. And then usually, as part of the test, is they'll do what they call an echocardiogram, which is an ultrasound of the heart. That's just part of the workup. And what they're trying to get in that picture is this. Whoops. Is to see.
That's why they put things on your chest, though.
The ultrasound is the echocardiogram is an ultrasound. It's a gel, and they put it all over your heart. Okay. And they're really, in that case, they're really looking at how do your valves work, how good your pump is, but it cannot just the echo determine if you have cardiac blockage at all. Okay. But it's part of the workup, because then they say, okay, if that's normal or abnormal, then they may do the next step. Okay. And they would want to do that before they did the stress test. So then the next point after the echo is the stress test. Now, the stress test is really just a treadmill test. Get on a treadmill, they hook you up. At the same time, they've got their EKG machine there. They're monitoring your blood pressure all the time. They usually have an oxygen thing on there, measuring your heart rate, of course, as part of the EKG, as you exercise. Okay, and typically the most common stress test that is done is called the Bruce procedure or protocol, and not Bruce, not you. A physician. So the way that it works on the treadmill is there's 7 stages, and at 3-minute increments, you are pumped up, either on incline and then also on speed. Okay, so every 3 minutes it changes. Okay, so you go through 7 stages. Okay, my friend Debbie didn't make it to the beginning of the 2nd stage. Okay, so the goal is to get yourself to the whatever the goal is, and I'll talk about that, and then to get to stage 7. Now, some people can't even get there because they're not physically fit enough to do a stress treadmill. Okay, so that becomes inconclusive, and that's not necessarily a good sign. But if you can make it all the way through a stress test, then and meeting your goals, then you can have a pretty good feeling about, okay, I think my heart's pretty okay. But you've got to be able to get to that point. So everybody says, well, what's the point? Well, they measure or set the target, at least for heart rate. They'll say, we want it to be your age predicted maximum times 85%. So it's not even 100. So the age predicted blood pressure is 220.
Heart rate.
Hmm?
You said blood pressure. Heart rate.
I'm sorry, heart rate. Thank you. Heart rate 220 minus your age times 0.85. And they'll say, okay, that's your target heart rate. So you get there. Then, depending on how you do, if you're asymptomatic and you're doing well, the physician may push you up to 100% or more. Okay? That's really going to depend on the results of the test as you go along. Okay? If you come up to the stage 7 and you do a great job, they may want to still push you. Okay? If you're not have any symptoms at all, they may not do that. You at least got to get to the 85%, and it's best if you can push it to the 100, if you get that far. Okay? Yes?
Do you have to, I'm not sure how the test works, or do you have to be capable of jogging?
Walking.
Oh, just walking?
But you're going to be speed, it's going to get up, and
Okay,
you're
but
going to
just
have to
walking,
go. Yeah.
because I couldn't jog if I liked it.
Well, you may feel like you're jogging by the end of it, but yeah. Because if you make it to 7 stages, you've got an incline of about 22%, and you're walking 6 miles per hour. That's pretty brisk. Okay, yeah, so, but you gotta get there, yes.
Isn't that done on a cycle?
They can do it on a bicycle, which typically is treadmill walking, but it can be. Particularly people who might have some problems with the walking, they may do it on the bike. Yeah, so it can be. Same concept though, push, and go through the stages.
We talking about heart rate then, we couldn't hear very well.
I'm sorry?
We talking about heart rate or pulse, would we say?
Yeah.
Yeah, and a typical being,
They're going to measure your heart rate up to that maximum number that they're looking for. And they're gonna calculate that
yeah.
based on that age predicted maximum. So 220 minus your age equals.
My normal pulse rate for a few years is just over 50.
Yeah, well, I got the same problem. So, you may take a while to get there.
What?
You may take a while to get to your maximum.
Oh.
Now for me, when I did mine not that long ago, I had to start high because they didn't want to wait 20, 30 minutes for me to get to my place. But it still has the same effect. It gets you there, yes.
I did a stress test, but while I was doing the stress test, some other nurse or doctor came running in and said, stop.
Yeah, good.
And because they did the thing with the abdominal sound.
Oh, yeah, ultrasound,
And it appeared I had an abdominal aorta aneurysm.
Oh my gosh.
So I had to stop right away.
You didn't fail the stress test. They just stopped it because they saw what your other problem was.
And I went
And that's why they
straight
do
to
the echo.
ICU.
That's why they do the echo, because they want to make sure you physically should be able to
But they
pump
only
your heart.
they started already the stress test
Yeah.
before they had the result from
They shouldn't have done that.
Yeah.
Yeah, I would have, yeah. Yes.
Real quick, do you know if there are any bicycle stress tests in Chiang Mai?
I really don't. I'll be honest, my familiarity is with Sebring. That's where I've done almost all of the work that I've done with my colleagues. So I don't know, but they might. The regional hospital might. Yes, Edwin?
There is a bicycle stress test at Med Park Hospital in Bangkok.
Yeah.
Med Park.
Okay, thank you.
Okay, so what will the stress test show if if you have abnormalities of flow to the heart, back to here. Oops, doing that. That it'll show up on your stress test. You'll have EKG changes, you might have arrhythmias like what happened with the case study number 3. So it will show up there. So goes to the next question is, let's see if I want to say something here. Oh yeah, there's a classic telltale sign that if there are changes, what they call in the ST segment, the heart goes PQRST. Okay, so the part between the S and the T has a look, okay? And so it can be depressed, the look of that, and the physician will be able to tell that. That's a telltale sign there's not enough oxygen getting to the heart. They know that right away. ST changes. That's exactly what happened with Debbie. ST changes. Not with the other case. The other case was arrhythmias. Hers was the ST changes. And right away. Okay.
Is that the ST in STEMI?
STs, huh?
Yeah, that's ST and related.
ST.
No, ST, it's just if you look at the EKG, they tell you this part, P, Q, R, S, T is the way the heart looks. And those are just things they put there. I don't say that, but it's different, yeah. But that's just on the EKG. Okay, so what next? So the next step, okay, you've done the stress test. Now, what if you become positive or inconclusive? What do you do next? Okay, so let's well, hopefully we don't get there. Okay, so, and we've already talked about this. The next step is to do further testing. Now, in some places, and not necessarily the norm, but if you have a positive stress test, they may do a stress echocardiogram, where they would say, okay, we're going to take a baseline, we're going to exercise you, and then we're going to take another echo, and that can maybe show some changes. The next one, which would be a little bit higher sophistication, would be a nuclear stress test, where they actually put in a nuclear dye where they can actually view everything much more clearly. Okay, now the gold standard, which we're not gonna get there, of whether or not you really have a problem is to do a cardiac catheterization. It's where they actually go into the heart with the camera and everything else, and they look at your heart. Well, that's not practical, okay? So what is typically done after a positive stress test is to go for a CT angiogram. It's a CT, it's a scan, an angiogram meaning they put a catheter in your femoral artery, go up to your heart. They don't go all the way in, and then they get up there high enough, and then they'll inject a dye that's a contrast media, and then they can look on the CT scan like an X-ray and see what the flow looks like. Okay?
Is that painful to have?
No, it's not. It's really, you don't feel anything. You goes through here. There's no pain. After they finish, you put pressure. They don't even have a suture afterwards.
Okay.
Yeah, it's really not very painful at all. You don't feel it.
CT
Huh?
what?
It's called CT angiogram.
You get a little bit hot in your head.
Huh?
You get a little bit hot in your head from the dye.
Oh, okay. Yeah, you can have some reaction. Yeah, you're right. Yeah.
But are you saying that's the gold standard?
No, that's not the gold standard. The gold, that's just the angiogram, because it's not a catheter that is being thread all the way through the heart, through all of these pieces. That's why I say it's the gold standard. If they can go in there with the camera, look at all those things, and they can tell you exactly how and precisely what the problem is.
That's a step up.
Yeah, but
They don't go straight down.
yeah, it's not practical, and it's not recommended. You're not gonna say, oh, let's go get everybody get a cardiac cath as your workup. No, but and no, not cheap, of course. And there's dangers related to that. So if you have an angiogram, then it will tell you how much blockage you have. Now, it can only tell you anything greater than 70%. It may not be able to pick up the smaller the ones that are not so big. But like our colleagues here had, 95%, 90%, 80+% blockages. Pretty easy to see. Okay.
Would it be safe to say that everybody has blockages, only the degree?
Oh, I don't want to say that. I would say, for me personally, I would say yes, but I don't have any scientific background that says
but
that.
it sounds logical from what you say, 90-95%, that you really should do something and you notice it. 70 is still okay.
Yeah,
So my conclusion, everybody probably has to some degree some blockage, and that makes sense too.
Yeah.
You can measure plaque formation from the age of 5.
Oh, there you go. But this is what
Yeah, and I want to go back on that. I want to go back on something though. That
no, because the kids have some other condition or congenital disease.
But how would you measure it at such low?
Because they've had open heart surgery.
yeah, they've got already compromised systems.
So we know it's there.
And I didn't mention this, but I want to go back to this from one of the folks' cases, person who religiously monitored their calcium score. And it was fairly normal, but look at the blockages he had, okay? So I would say if you're gonna do calcium scores every year to 2 years, 3 years, it's just a risk factor. Please don't think of that as a diagnostic, because all it's measuring is calcium. And so as we know, I said the plaque is made up of cholesterol, some waste, fiber, and some calcium. So you can have normal calcium score and still have major blockages, which exactly happened to case 1. So just don't take that as a diagnostic, okay? I didn't mention that before. So I guess then we go to the next step is that, okay, now I've done this test, it's positive, I have an angiogram, and I've got significant blockage. What are my treatment options? Okay, there are basically 2 treatment options, a stent, which we call angioplasty, and bypass surgery. Okay, so talk a little bit about the angioplasty, which is basically, okay, this picture shows what an angioplasty looks like. It's really a balloon that goes in there, expands to open it up, and then they put a kind of a mesh coil around there to keep it open, and that's what that is. Okay, that's what a stent is. It opens up the blockage. The balloon does that, and then it takes maybe 3 months to 1 year to get totally where all the tissue grows over that. Okay, So, but that doesn't matter. Usually the recovery time after the stent, 1 to 2 weeks, you can get back to most of your normal stuff, okay? That's assuming you hadn't had a heart attack, you just had the quiet and you got the stent.
Is the balloon not blocking the artery then? Is that
Yeah, then they take it out.
Oh, okay, they
Yeah.
take the balloon out, okay.
Like what? No, well, yeah, they do.
Because otherwise there would be no
Yeah,
room
yeah.
for blood.
Unless now, it's a very good question, yeah. Yeah. Okay, what do I want to say about that? Oh, and I said before, is that you might need more than one to do the job, okay? Okay, so just having one, whereas, case number 3 in the right corner area was pretty blocked. He had three stents to open it up, okay? So, but once they're in there, they can put the stents in there, okay? Now, they can't maybe do the right side and the left side and do a whole bunch at one time. It depends on the situation. You obviously want to do the most serious one first.
Francis,
Yeah.
how long after the stents go in, will they like to keep the artery open?
They will.
For how long?
For how long? That's a good question, because the downside of a stent is that you can have a new blockage just like you did before in the same spot. So stents are very good and successful, but you may have to have another one. So if the physician feels like he did a good job putting maybe 2 stents in, he might say, okay, you probably got it 10 years. They'll tell you about what they think that's going to be. But you can get another blockage at the same spot or someplace else. That's kind of the downside of the stent. Yes, Patricia?
Can they put in the stents without breaking open the chest?
Yeah, that's strictly through the femoral artery. Same way that they do the
Oh,
test.
same, okay.
But Glenn was saying, he was prepared, if they show the blockage, they were ready to put the stent in right then and there.
Okay.
That's part of what they do.
And not just from the femoral artery.
Yes, they can. Yeah. Is that what, yeah. Typically, they'll do the femoral, but it depends some on the physician and what they prefer. Yeah, yeah. So, yes, Patricia.
My mom had an angioplasty 35 years ago. So maybe technology is quite a bit different.
Yeah, probably so,
She had one and it wasn't successful, and they said she was limited to 2 because the walls of the artery get thin. But the second one was successful. She put 35 years on it.
Yeah.
Did not die of a heart attack.
Yeah.
I mean, the nice thing about the stents is, although they gradually fail, it gives blood vessels around about a chance to develop, and you get collateral circulation. So you usually, even though the stent might not be working after 10 years, the circulation to the heart is still good.
Yeah. And it depends on your individual situation. If you just, like for the case number 3 with his blockages, he could have easily been a candidate for bypass surgery too. It's your choice on that. And the bypass surgery is much more invasive, but the long-term outcome is much better. But that's the one where they open your chest. So,
Okay.
so, and usually the bypass surgery is for those people who have lots of, severe blockages, high percentages, multiple, So they are going to be a better candidate for that. And that's exactly what happened with Debbie is that she was not a stent candidate at all. So she had to go for the CABG. And I know it sounds scary, but these days it's not as bad as it, I started my nursing career a long time ago with some very high Dr. Cooley and them in Med Center in Houston, and they pioneers, and that has really changed a lot since then. But
When the chest gets broken open for a bypass, is the recovery not extremely painful because the ribs keep moving?
yeah, because they have to cut the sternum. They got to cut it and open it up so they can see your heart to work on it. So that's got to heal. The bone's got to heal, just like any bone that's broken.
Not as bad as you think.
And it's tight, but it's not.
Because the sternum's not moving, the ribs are. But you split the sternum, so you've got the bone,
Okay, split the
and
sternum.
you've literally wired it together now. So
Okay.
And then you wired it together. But it's definitely, it's not going to be pleasant your first 24, 48 hours. But don't keep you sedated. They aren't going to let you be too awake with that. So slowly wake you up. But the recovery time is longer. You're talking, definitely a month, up to 3 months, can be up to 6 months to be back to 100%.
Yeah.
My 87-year-old stepdad had triple bypass surgery.
gonna have quadruple, all 4 of them. We're gonna go in for 3, why not take the little one, you know? And, you know, it really, it's quite simple how it works, is that they basically bypass the blockage. They use your veins, sometimes in your legs, sometimes in your mammary glands, they'll use the veins as the ways to go around it. It's kind of like a plumber. If a plumber has, you know, how they work, there's a clog here, let's go around there, you know, particularly here in Thailand. Don't fix it, just go around it.
Here it's in concrete.
But I mean, it sounds more simple than it is, and it's scary, because you have to be on a machine that takes all your blood out and brings it all back, and it's not without its complications, but it's not as dangerous as it used to be, I would say, in the older days. But that may be a better option for some people. Okay.
And one step further would be a new heart. Because you only picture pretty grim pictures like.
I'm not trying to do that, but I'm trying to get.
So what's the next step? That will be, I mentioned a new heart, which is not that easy.
No, and then you're not, at 80 years old, you're not gonna be on the list, you know, for most likely, I mean.
10 years, you're going to get your 3D printed heart.
All right, let me show you just the kind of conclusion before, because we definitely have taken up more time than I thought, but up to you guys. All right, this is a before and after picture of case number 3, who had the right coronary artery blocked at 90+%, okay? You see before, can you see those arrows, and you can barely see any flow there? This is the dye, okay? And then after, look at all this. Ooh, big old fat tube. And look at it, it goes, yeah. Okay, so that's very successful. That's the one that had 3. I had to put 3 in. I can't really see, but I'm thinking one here, they're kind of, I'm not sure. I can't tell you for sure exactly. But the whole point is to see the before and after. Okay, so stents work, okay?
No, that's a bypass, is it?
No, this is just a stent put in, just the stent.
Stent.
Just the stent,
Oh.
no bypass. It would look different on a bypass because you'd see a different flow. Okay, and then this one is, where on the left side is where the other arteries were affected. And you can see at the beginning, you kind of,
See the stent.
you can see here, not flow, a little tight right there, a little tight there. But then after, there's the flow, good flow, see that? You can barely see that there. And look how far down it goes now. See here, it kind of stops. So now we've got good blood flow down to the left LAD. Okay, stent. Okay. So it shows, again, it works. Okay. Questions at this point on the information presented?
You mentioned the medical history. Like on my father's side, they all died in early 50s, or the eldest was 61.
Mm-hmm.
On my mother's side, they 10 kids,
Mm-hmm.
and they all died at 95, 98, 97, no heart problems. How does that come down to me?
Well, you had a 50-50 chance. No, definitely history of heart disease in the family, that hereditary factor. Unfortunately, you can't do much about that, but it is a precursor. Like Debbie, her father had bad heart disease, had quadruple bypass surgery. It's in the family. Okay, so
you can do genetic studies now to find out.
Yes, Edwin.
Hi, Francis. Are there any other blood tests proper that might be good markers for coronary heart disease? Simple blood tests.
No. Not really. No. No. The thing is, the thing about the stress test, it's pretty accurate if, you can make it, but the angiogram doesn't lie. I mean, you can't, why, somebody said they're gonna go for a second opinion. Well, what do you think they're gonna find on that second angiogram? You see, there's no flow and there's flow. Okay, so, you hope you don't have to get to that point, but if you do, and that keeps you alive, then and you have pretty much a normal lifestyle after that, Yes.
Wouldn't you, mean, if you have problems, wouldn't you push them for getting the best test you can, and not just stop at a certain stage? It's just a bit of money, yeah.
Yeah, I mean, for me, I would probably insist on pushing me. If I was fine at the stage 7, I would
Yeah.
say, push me, please. Because I have a
Yeah.
history of heart disease and my family too.
I
so.
had, high cholesterol for like 30 years.
Mhm.
I said to my daughter, I said, I want a CT scan. And she said, yeah, fine. And yeah, it was all good.
Yeah.
But I mean, I had experience with blood clots, and they didn't find that after before 3 months. And I should have told them, from the beginning of that this is not working. I want a CT scan.
Yeah. And here we have that luxury. Some places are going to say we have to do this before we do this, before we do this. But I think the minimum you need to get the stress test, and then whether or not that's positive or not, or borderline, you can say I want an angiogram. Okay, and there was another question, Lois.
I was just, with my mother, she was 86, she had that massive heart attack, survived it, but took her right away in for the cardiac cath. Found extreme blockage, tried to call me, I was at work, and this is where having 2 power of attorney, medical power of attorney came in here. I was at work, had my phone off, they had her on the table, called my sister and said, we needed to go into quadruple bypass surgery or not. Like, we need to know now.
Yeah.
She's on the table.
Because she had the heart attack. She already had the
she already
damage
had
done.
the heart attack. She already had the damage. So my sister had to make that split decision. And we knew that Mom had said that she was ready to go.
Yeah, you're right. If you have the complication of the heart attack, then people might do things a little faster. They would do the cardiac cath maybe. You came in with severe angina, they might. But for us, if we're just trying to do a routine workup and we don't have symptoms, we don't think, then we go the route we're going. But if you got a heart attack, then there are going to be maybe some different protocols that are going to be followed. Yeah. Okay. Any other questions? Oh, yes, Edwin?
Francis, a couple of years ago, I read a study out of Mexico. It was a longitudinal, double-blind study. It showed that people that took their blood pressure medicine in the evening had a 40% greater survival of all-cause death than people that took their blood pressure medication in the morning.
Yeah.
So naturally, we switched to taking our blood pressure medication in the evening. So I just pass this along for general interest.
And it's probably, a lot of the medications now, the nice thing is they're only once a day. So if you take it in the evening, you're still taking it once a day. You know what I'm saying? Yeah. I don't know anything about that in particular.
Yeah, I read the percentage is a lot lower, but it's still like 15 to 20%. But the point is your blood pressure is the highest in the morning. And I think that's probably why taking it at night. It's more active in the morning.
With the older treatments, yeah. But if you look at the modern drugs now, the half-life is pretty constant through the 24-hour. So that study, if you did it now, I don't know if you'll get the same definite change.
But the point is, you're taking your medicine, you choose to take it at night versus the morning, and it's working for you.
Yeah, but the older medications used to peak.
Yeah,
and
right,
drop off.
exactly. Now,
modern
right.
medications tend to be much more accurate through the 24. So I don't know. I've seen that study as well, but I've seen other studies since saying with modern medications now, it's not really making any difference. The secret is to
But
make sure you take
hurt.
it every day.
It doesn't hurt taking it.
No, it doesn't hurt.
No, it's not hurting you.
It's just a question what your
But
routine is.
Edwin's right, the typical thing, take it in the morning,
The secret is to make sure people are taking it.
Yeah.
The trouble is, you take it at night, you've gone out for an evening meal with some friends, you've had a couple of beers and you forget.
The answer is don't have the beer.
Yeah, right.
Well, then, doctor, will I live longer if I don't drink? No, it will just feel like it.
Yeah. Okay, so here you are now. You've heard the stories. So if you were to go on your own and say, I think I want a cardiac workup, where would you go? Okay. Pretty much all the hospitals here have a heart center or heart department. I have only personal experience with Sebring, okay? So, and I have some experience with Smithy Way in Bangkok, but in terms of Chiang Rai, that's my experience, okay?
Chiang Rai Central has a really good unit, but it's incredibly busy.
Yeah.
Like a public hospital, you've got slight issues.
Yeah.
Mayfai Luang now has an excellent, the consultant that set up Chiang Rai Central moved to the medical centre there at MFU, the new
Okay.
hospital, and that is a fabulous unit as well. But busy, because unfortunately the rate in Thailand of strokes and
Yeah.
cardiovascular disease is just going through the roof. It's like the UK back in the 70s.
And what would you say about Bangkok Hospital here, do you know?
Bangkok, I don't know.
I don't
They
think,
do have cardio, ESD, they can do, they have cardio.
I think pretty much, you know, you're gonna have that basic, okay, up to the angiogram. Now, not everybody's gonna do cabbages, I can tell you that. But my experience, at least with what I know about the Chiang Rai Regional, they're the big hospital. They've got the equipment, they've got everything you need, but to try to do preventative things here, like he said, it's busy. So, you know, you might wanna say go in, and you say, well, you know, your appointment's 6 weeks from now. You know, you don't wanna do that. Now, if you're coming in with a heart attack, they're gonna treat you a little differently.
Oh, yes.
But if you want a workup, is what we're saying. So, but the thing, oh yes, Marty.
I was just going, doesn't it a lot depend on the particular physician? Because I've had some Midday, and the first one I had, she almost killed me by double dosing my stuff.
Your blood pressure medicine, yeah.
And then the other one, the one I got as a replacement, because I fired her basically,
Mhm.
and I asked the nurse, who do you recommend it?
Yeah.
I can't say. I said, who would you recommend if it was your father?
Yeah.
I don't know, but Dr. Mann is really good.
Yeah.
And that's what I found out to get, and he's fantastic.
Yeah.
But it seems like it varies so much. You can get such a crappy doctor here, and then such a good doctor.
It's the same.
Yeah,
the secret is to get quality in this, you need quantity of turnover. So just because somewhere's quiet and you can get your appointment quick, it means they may not do very many and they might be absolutely useless. You better go into a busier unit where you know they've got the throughput.
Yeah.
Okay. Whether it's plastics, but that's the same for anything. If you want a hip replacement, you don't go to the hospital that's got we can do it this afternoon. When did you last do a hip replacement? Oh, 3 years ago.
Yeah. Well, and that's why I said my experience has been in
Go to the
Sebring.
busy place.
I know, I worked with 2 people there, and I know all 3 physicians there. And, you know, they do, the stress test is just right on, so no problem with the stress test. Angio, no problem. Never got to the cabbage on the other one. But the thing is, what you go is, you know, you gotta be a little bit maybe more aggressive and say, okay, I want, number one, you're talking to the receptionist. I want to see the cardiologist. Number one, okay? So then they might say, why do you want to do that? Well, because I want a cardiac workup. I want a health screen. I want a stress test. So say those things so that they know that's what you want, and then they can do that right away, usually, okay? But like I said, the public hospital, good. If you're having a heart attack, that's where you want to go. Now, if you want to do your workup, you may not. It's just, you know, up to you, and whether or not you choose to do something like that. Okay. Yes.
One question again about the stress test. If you're over 60 and you don't have any symptoms, how many times every many
if
years
you
have
okay,
to
you
do
do
the
well.
stress test? You think is
Yeah, I think, you know, if you pass the stress test, no problem. 3 to 5 years. You know, if you start having some symptoms, then sooner. But yeah, and then as you get older, you might do it more often. Like for, you know, maybe once. If your stress test is okay still and you're getting older, you might do it every other year, or you might choose to do it every year. Up to you. You know.
Just on that, when I last did my stress test after my heart attack, there is a line on the result that says probability of living another 5 years. In my case, 95%.
Okay.
So you know you're pretty good for the next 5 years.
Yeah. There's some predictability to that. Now, and the other thing is no guarantees. Even no guarantees.
Probability.
Yeah, and even with the stent, you know, even though you had the stent, or you had a positive stress test, that piece of plaque, like you said, could break off. And guess what? Depending on where it breaks off, you could have a heart attack. So that doesn't mean anything we're talking about is 100%. Just that these are things that you can do to prevent, and to be a step ahead.
You're talking, most of this stuff is
direct intervention, stents and so on. Now, you just mentioned many mentioned taking different medicines.
Mhm.
What about traditional Chinese, Thai medicine, or in any country? What's been working for, modern doctors don't like that for some reason.
Yeah, I don't
Is it
know.
because it doesn't work, or is it because?
I think it's depending on what condition you're going to trying to treat yourself, whether or not alternative / medicine would be beneficial for you. Like people have acupressure, acupuncture for maybe some joint pain. Well, that's probably pretty good. I don't know if I'd want that for my heart.
I've had eye problems for over 2 years now.
Yeah.
And my neurologist said, no, it's not a neurological problem, but I don't know what it is. You should go to Bangkok to see a neurologist specialized for eye problems. But this was in the middle of COVID, so I said, no, I'll wait. And I did a visit in Lekwart, and there was an acupuncture clinic, and I went there. And within 3 treatments, my eye came back to normal.
Yeah, okay.
Almost.
It works. I mean, I have a scientific background as a nurse, so I believe in some of that, and some of it I don't. It depends
The
on.
neurologist does not believe in acupuncture.
Yeah. Okay. Yes. One more question.
So, the best hospital is what, Nepal, Luang?
I don't want to say that. It's really hard.
You need to go where they do plenty of cases.
But that is an excellent one, you're saying.
The Central Hospital is very good. That's a great cardiology unit, but incredibly busy. And then the new hospital at MFU's got really state-of-the-art equipment. Very good. The cardiologist is excellent. So it's not as busy, but it's still busy enough. So I would probably say that's probably round here.
The new Mayflower Hospital.
Yeah.
The university, the new one.
Yeah.
Now, my experience was when I went there, they didn't have this new person, and I was not impressed. So now that they've got a real heart center,
It's
that's
really
different.
good.
Like I said, my experience has been with Sebring. That's just because of the two cases that I worked with on, and knowing and meeting the physicians and that kind of stuff. And they speak pretty good English. Actually, that's good at Sebring for sure. And probably they are.
He does it.
Yeah.
Just one quick note on that, which hospital here and there. You have to be careful of what health care plan you're on.
Yeah.
Oh, yeah.
Because some healthcare plans won't cover you under a regional hospital.
Sure.
It has to be.
Yeah, you have to be in that one.
Yeah.
If you're going to use your insurance, then you definitely need to go a couple of steps to figure out the best place.
Say that again, please.
If you have insurance, you would want to go in network with whatever your insurance plan says. So if they don't practice at this hospital, then don't go there.
And how much might it be if you don't have insurance for it?
And you pay.
650,000 baht.
But that's for his whole procedure.
150,000.
650,000.
But remember, he had all the way through to the stent. We're talking about you just want to do some stress test.
No.
Well, if you want to do a cardiac workout, might cost how much, I'm asking.
Well, you know what, I don't know the answer to that, because the only ones I've had went all the way through like he did. So they'll give you a price. It's actually a pretty standard workout. So you say, how much is it gonna cost you?
Well, I had a CT scan, but that was on the lung, but that was 18,000 baht.
Yeah, you can.
That was at
oh, wait.
Overflow.
Okay. And they have a heart center there too. You know, I think now at least you're armed with a little bit of knowledge, so that they don't shortchange you. You might say, do you do the Bruce protocol? You know, you can ask them a couple of things. They do it Sebring, I know that. So, but
If you're doing a follow-up, which will be sent to the correct, can you put some of these questions that we can answer?
yeah.
Please?
Yeah. Okay. Yeah. Okay. Anything else? Any other comments? Yes, sir.
How much does a stress test cost in Sweden, for example? Because some insurance, they don't take care of prevention, they only pay for.
That depends on your insurance policy. If you came in with symptoms, most likely. If you come in just for prevention, I don't know.
But how much does a test if you are going to pay by yourself? A stress test?
I don't know the
It's
answer to
not
that.
cheap, because if you're having a stress test, you might have a cardiac event.
Yeah.
So for you to have a stress test, there's a full cardiac team on standby, including the stent team.
So it really depends.
So, you know, it might start at 20,000 baht, and then it might end up at 150,000 very rapidly.
Okay, I
So
can,
this is the problem. It's a,
If they are going to react to something.
yeah. So you have to have the team on standby. In theory, when we first started doing stents, you had to have a full thoracic surgery team
Yeah,
on
yeah.
standby in case they messed up the artery and you had to go straight into open heart surgery.
Yeah.
So that was a real issue. Now that's not an issue because the
No.
technology's moved on so far.
and the physicians are trained as actual cardiac interventional, that's their specialty, they're used to doing this. But to answer your question, I cannot, if you just get the stress test and you do that workup, I don't know what the cost is. If you have to go all the way through, to angiogram, but not stent, I would say, my friend, it's about 100,000 baht cash. But no stent, just through the angiogram. Okay?
Maybe we could say that if people after this, after this, we're going to do a note that
Yeah.
kind of summarizes what we said. We've got a recording there. If people get some information, if they'd share it with me or with Francis,
Yeah, then we
all
can-
of you who've given your name, your email address, we can start to build up some picture of what the cost is at different hospitals.
But one thing, like I've had EKG or a stress test where I had to pay for myself,
Sure.
and it wasn't expensive.
You had only up to the stress test and nothing else after that.
Correct.
But did you
I
have
did
lab
not.
work, the
I
echo?
did not.
Did you have the echo and all that?
No, just the stress test.
Just the stress test.
As my normal annual cardio
Okay.
checkup with my doctor,
Mhm.
but it wasn't much.
Relative to.
Yeah.
No, but why would it?
Yeah, so, but,
It
see,
really wasn't much.
he just went for the stress test, he didn't go do all that. So that's all, he had all these things up, and I said, you should have.
Okay,
If
so
you're gonna do a
basic.
baseline, you should have all those.
Okay. My question was, why should I be concerned about this?
It's up to you.
It's just,
It's up to you. If you are concerned about, I can have a cardiac event again, and I don't want that to happen, then you have a choice. If you say, I don't really care, you have a choice. I don't mean to say it that way.
no,
but
I
it's-
didn't mean it the way you're taking it, so I
Okay.
apologize for that.
Okay.
But as a healthy individual, at what point in time do I concern myself with this? Is it my age, how I feel? What should prompt me? Is it just part of my normal health checkup? When should I do this?
Well, okay, gosh, that's a good question, Ray, because it's all individual. But, if you have absolutely no symptoms and not too worried, your blood pressure's good, cholesterol's good, you say, well, I'm not gonna worry about it. If you have some symptomology at all,